All right, in this explainer, we're going to tackle one of the most critical challenges in orthopedics, vertebral fractures. We'll break down how these complex injuries are diagnosed, the core principles that guide surgeons in the OR, and ultimately what the end goals are for getting patients back to their lives.
Okay, so to really get a handle on what happens when the spine breaks, we first have to appreciate what it does when it's working properly. The spinal column is so much more than just a stack of bones. Its integrity is absolutely paramount for, well, pretty much everything we do. And right here, this is the fundamental tug-of-war in every single spinal injury. You've got this structure that needs to be an incredibly strong pillar for movement, but at the same time, it has to be this delicate protective shield for the spinal cord. Every single decision, from diagnosis to treatment, is about balancing and preserving both of these critical jobs.
So a patient comes in, and you suspect a spinal injury. How do you go from just a suspicion to a definitive diagnosis? Well, it's a very systematic process. It's not just about snapping a quick X-ray. It's a full-on clinical evaluation. You know, the path to diagnosis is actually pretty clear-cut. It's a multi-step journey that starts with just talking to the patient and ends with some pretty advanced imaging to get the complete picture of what's going on.
This three-step process you're seeing here, history, exam, and imaging, this is the absolute bedrock of spinal diagnostics. This is how we figure out not just what the injury is, but how it happened, and probably most importantly, what kind of functional impact it's having on the patient. Okay, let's really zero in on that third step, imaging. This is where we get to actually see the injury. We've got several different tools in our arsenal, and each one gives us a unique layer of information. And picking the right one is absolutely key for planning a successful treatment. This table does a great job of showing how each of these imaging types gives us a different piece of the puzzle. An X-ray, that's our initial scout film, the basic overview. But the CT scan, that's the gold standard for bone detail. It's like the architect's blueprint for surgery. Then you've got the MRI, which lets us see all the soft tissues, ligaments, discs, and crucially, the spinal cord itself. It tells us if there's neurological compromise. And for those subtle compression fractures, scintigraphy can light them up by showing us metabolic hotspots.
All right, so the diagnosis is locked in. Now the focus totally shifts to treatment. And everything here is guided by a few core surgical principles. It's all about bringing back stability and protecting that neurological function. And this right here is the key takeaway. Every single decision a surgeon makes, from the first cut to the final suture, is aimed at hitting at least one of these three goals. It's this constant balancing act: restore the mechanics, protect the nerves, and get the patient on the road to recovery as fast as possible.
So how do surgeons actually achieve those goals? Well, they have four fundamental techniques in their toolkit. Let's break down what each of these are. First up, you have resection. The easiest way to think about this is decompression. It doesn't matter if it's a bone fragment from a burst fracture or a herniated disc, the goal is the same. Get it out of there, create space, and take the pressure off the spinal cord or the nerve roots. Next is osteosynthesis. The best analogy for this is internal scaffolding. Once you've put the fracture back where it belongs, you have to hold it there, right? That's where all the hardware comes in. Plates, pedicle screws, rods, providing that immediate, rigid stability so the bone can heal in the right position. Then there's fusion, which kind of takes stability to the next level. The goal here is to create one single solid block of bone, an arthrodesis, which gets rid of all motion in that segment. You're basically trading movement for definitive long-term stability, which is why it's so often paired with osteosynthesis.
And finally, we have defect filling, which is a much more minimally invasive approach. For certain compression fractures, especially in patients with osteoporosis, procedures like vertebroplasty and kyphoplasty are amazing. We can inject medical-grade bone cement right into the broken vertebra, stabilizing it from the inside out. It can provide incredible, almost immediate pain relief.
Okay, so let's tie this all together. We're going to look at one critical clinical pearl that can literally prevent a misdiagnosis, and then we'll recap the ultimate objectives that guide this entire process.
Now this is a clinical pearl you have to burn into your brain. When a patient has a calcaneal fracture, that's the heel bone, from falling from a height, that force does not just stop at their feet. Nope, it travels straight up the kinetic chain. This is the absolute classic mechanism for an associated axial loading injury to the lumbar spine.
Forgetting to check the spine in these cases is a really common and, frankly, a very dangerous oversight. And it's pretty clear why this matters. Missing a vertebral fracture can lead to devastating, permanent neurological damage. So always examine the spine.
So, to wrap it all up, the entire treatment pathway we just walked through, from that very first X-ray to the final choice of surgery, is all driving towards these three definitive outcomes: a stable, pain-free spine, a nervous system that's protected or recovering, and a patient who can get into rehab and get their life back.
And this really brings us to what's next. You know, for decades, fusion has been the gold standard, trading motion for stability. But as our technology gets better, as our understanding of biomechanics deepens, the big question becomes, can we achieve that same rock-solid stability while preserving the natural motion of the spine? Answering that challenge? Well, that's what's going to define the next generation of spine surgery.